So in this session, we're going to be talking about umbilical cord prolapse. We're going to be looking at the national guidance and management of this time-critical emergency. So important points to remember. We need to understand how maternal positioning can reduce pressure upon the cord. We need to know how the clinical circumstances, environment and urgency should inform the best position to recommend for the woman to be in. We need to use appropriate manual elevation of the presenting part and or bladder filling depending on your clinical location and circumstance. We need to understand the importance of not handling the cord and protecting with a dry pad if appropriate. Recognising also that this is a time-critical emergency requiring immediate intervention, including transfer to the labour ward of a consultant-led obstetric unit. When transferring from the community setting, it's also important to remember to avoid using a service chair to move the woman to the ambulance. So everything that we're going to talk about today is based upon national guidance, so that includes the NICE guidance on inducing labour and also intrapartum care for healthy women and babies, and also the ICOG's umbilical cord prolapse green top guidance as well. So looking at the NICE guidance for inducing labour and intrapartum care, it tells us that obstetricians and midwives need to palpate for the umbilical cord presentation on any sort of initial and subsequent vaginal examinations that are performed as well. And also to reduce the risk around induction of labour, we need to make sure that obstetricians and midwives are performing abdominal assessments as well to establish the level and also the stability of the presenting part, to ensure that it's in that lower part of the pelvis prior to any artificial rupture of membranes. It may be that we need to have assistance to manually stabilise the presenting part if needed, possibly with a Paulix grip. We need to make sure also that we avoid dislodging the baby's head during any vaginal examination as well. And also to make sure that we check for the presence of a prolapsed or presenting umbilical cord after artificial rupture of membranes is performed as well. So looking at the definition of cord prolapse and what we currently have as well. So as we know, umbilical cord prolapse is an unpredictable obstetric emergency, and it's currently defined as a descent of an umbilical cord through the cervix, either alongside, which we can call a colt, or past the presenting part, which we also know as a vert, in the presence of ruptured membranes. So the risk or incidence of umbilical cord prolapse is between 1.1 and 0.6% of all births. However, we also know that this increases to around 1% in breech presentations. Most cases of cord prolapse occur when the amniotic membranes rupture, and that can be either spontaneously or artificially. And we know also that cord prolapse can be associated with a high perinatal mortality, around 9 in 1,000 births. Although cord prolapse-related adverse outcomes are mostly associated with fetal prematurity, birth asphyxia can occur as a consequence of cord prolapse, particularly when this occurs outside of hospital settings. The interval between diagnosis and birth is a contributory factor to the risk of stillbirth or perinatal death also. So really, to summarise, this is a time-critical emergency. So when we're thinking about risk factors and factors that we should have an awareness of, particularly around cord prolapse, there are some, as you can see, are within the antenatal period, such as breech presentation, multiparity, fetal congenital abnormalities, unstable, oblique or sort of transverse lies, polyhydramnios, low birth weight, and also a low-lying placenta. So for a lot of those risk factors, it's where the presenting part won't engage well within the pelvis. And also intrapartum risk factors, so breech presentation again as we just discussed, unengaged presenting part, prematurity, and also that second twin. And there's also some procedure-related risk factors that we need to be aware of, and the fact that they can lead on to having a cord prolapse. So an external cephalic version, amniotomy, particularly when you do have that high presenting part, internal pedalic version, disimpaction of fetal head during rotational assisted vaginal birth, or any other kind of manipulation of the fetal head where it's going to allow that cord to come down as well. An application of a fetal scalp electrode, or also a large balloon catheter for induction of labour. So these are all factors that we need to take into consideration when we're actually undertaking those procedures. So as discussed, that interval between diagnosis to birth is a contributory factor. So we really need to make sure that we exclude any cord presentation or cord prolapse following a spontaneous rupture of membranes, particularly when we do have existing risk factors there as well. Any sudden fetal bradycardia or any other normal heart rate should also alert us potentially to think about whether or not there is a cord prolapse or presentation as that cause as well. It can be diagnosed by either visualising the cord protruding from the vagina or also by palpation of that cord during a vaginal examination. But in preterm cases where cord prolapse is suspected with intact amniotic sac, it may be that we need to use ultrasound imaging to exclude or confirm that diagnosis as well. So after diagnosing and recognising the cord prolapse, the first thing that we really need to do is call for help and declare the emergency as well, stating what the problem is to our colleagues and to those around us. We obviously need to relieve pressure by elevating that presenting part, and this can be done in a number of different ways. So we have maternal positioning. It might be the knee-chest position, which we'll demonstrate a little bit later, or lying in the left lateral with pillows under the hip, mother's hips, to make sure that they're higher than the head. It could be that we use manual elevation of the presenting part, and we can also consider bladder filling if there's going to be a delay. And this is obviously important to pass on to the hospital or theatre team that bladder is filled prior to birth as well. We can consider tocolysis with some subcutaneous terbutaline as well if the woman is contracting. We need to make a plan for immediate birth or maybe transfer from a community setting to a consultant-led unit, and make sure that we've got experienced team members ready, including an anaesthetist, theatre team and neonatologist as well. Secure IV access and ensure bloods have been taken and sent, and continuously monitor that fetal heart if we're in a hospital setting. But really, we always need to consider the clinical circumstances, environment and urgency as to how this will be managed. So as you can see here, we've got an example of somebody in an effective knee-chest position. And this is an effective position for elevation of the presenting part because you have gravity assisting that elevation of the presenting part as well. It's really easy for somebody to adopt, for a woman to get into that position, but equally it's easy for somebody to describe over a telephone should they be receiving a call from a woman who feels that her waters may have gone and that she can feel cord or something between her legs as well while she awaits assistance. It's really important to make sure that when you are getting in this position, and you can see by this example here that head is as low as possible to really help with the level of elevation there as well. And it's a useful position if you are a healthcare professional alone with a woman that she can adopt whilst you are preparing another method to help elevate the presenting part, such as bladder filling, whilst you're getting all of that equipment ready. However, it's not a position that can be adopted once transferring in an ambulance. So this is a more appropriate position for an ambulance transfer, as you can see. So this is the left lateral position with hips raised and also head tilt. So we've got two pillows under the maternal hips with the bed tilted to maximise the position. So this is a position that can be used within a hospital setting, but also within an ambulance up on the trolley there as well. And the bottom of the trolley can actually be raised to help with that positioning. This is more of a safe position, particularly if you're within an ambulance, because the woman can be seat belted for her safety and security as well. But it's also something that can be considered when you have women with reduced mobility, potentially within a hospital setting or in the community setting also. It's important to know, though, that if you are in a community setting, in a setting that you're not able to get the woman straight onto the hospital trolleys, for example, upstairs in an upstairs room, that you ask her to walk from where she is down to the trolley, obviously when it's comfortable and safe to do so, so that she doesn't use a service transfer chair at all, because that may delay time and also increase the likelihood of cord compression. She can also use a dry pad to protect the cord. You can ask her to use that to just hold the cord up as close to the vulva as possible. Another consideration for helping elevate the presenting part is manual elevation. And this can be effective to elevate the presenting part. You just have to make sure that you're not inadvertently compressing the umbilical cord when you are performing this also. But also to consider that this can be uncomfortable for the woman, particularly if it's sustained for a long time, and also for the midwife or obstetrician who's performing that if it's maintained for a long time. And also it's not something that would be able to be maintained during an ambulance transfer, so that's when we would consider obviously using the bladder filling and that change in maternal position, so again that left lateral with the hips raised and the head tilt down as well. So as you can see here, these are 5 key steps for easy and effective maternal bladder filling. So obviously your initial step really is preparing that equipment and making sure that you have a good fit between your giving set and also the catheter that you're going to be using to insert into the bladder there as well. Making sure that you leave the bag in situ, so that when you hand over to the team in the hospital they can see that the bladder has been filled, and then also making sure that that bladder is emptied prior to birth. So everything that's been discussed about cord prolapse and management of cord prolapse is contained within this algorithm, which you can use and practice with on your training days, or use your own algorithm if you have one within your hospital unit also. So it just takes you through the steps of recognising, calling for help, simultaneously preparing for urgent birth whilst you're also relieving pressure on the cord. Also, obviously, planning for that birth, and then steps that you need to take post-birth as well. So also some considerations post-birth is thinking about taking your pairs umbilical cord gases, completing your documentation, and we've got an example of a proforma here which you may wish to introduce into your unit if you do not already have your own, but obviously you can use your own, and familiarising yourselves and your staff with that documentation is really important, and knowing where to find it as well. Also completing that clinical incident form, which the details from that proforma is going to aid you in doing so. Remembering to debrief the mother and her birth partners, and also debriefing the staff involved as well, because this can be a traumatic event for everybody and it gives everyone a good opportunity to talk through the events. So the RCOG have a really useful information leaflet on cord prolapse, which is available on their website, and this can be useful to either signpost or provide for women and their birth partners if they've been involved in a cord prolapse, and also to help when you're debriefing, provide a visual aid and a little bit more information for them to take away as well. So there have been 2 recent papers produced from teams in Hong Kong looking at different aspects of cord prolapse. The first paper was looking at the efficacy of the different manoeuvres used to elevate the presenting part during cord prolapse. And they looked at the current manoeuvres used and looking and found that some were a little bit more effective than others. For example, they found that the knee-chest position actually gave a higher level of elevation in comparison to some of the other methods used. And the next one after that would be bladder filling with 500 mils of normal saline. And the second paper also has looked into the different definitions of cord prolapse as well, and actually proposed an additional category. So alongside our current categories with cord prolapse and cord presentation, they've also proposed a compound cord presentation in the presence of with or without ruptured membranes. And to summarise the key learning points with umbilical cord prolapse, it's obviously important to understand how maternal positioning can reduce the pressure on the umbilical cord, how the clinical circumstances, environment and urgency should inform the best position for the women to adopt, to use appropriate manual elevation of the presenting part and or bladder filling depending on your clinical location and circumstance. Understand the importance of not handling the cord and protecting with a dry pad if appropriate, and recognising that this is a time-critical emergency requiring immediate intervention, including transfer to a labour ward of a consultant-led obstetric unit. And when transferring from a community setting, remembering to avoid using a service chair to move the woman to the ambulance.